All right, hello everyone. Welcome to today's presentation. I'm Sam O'Hara. I'm the Director of Orthopedic Services at Holy Redeemer Health System. I'm going to start with a quick disclaimer before we begin. So this information presented today is not intended to diagnose, treat, or replace the advice and care of your healthcare team. Please contact your healthcare provider for advice and treatment as it pertains to your individual situation. All right, so a few housekeeping items. This program is being recorded. All attendees are muted for the duration of the program. Attendees will not appear in the video. A Q&A session will be held at the end utilizing submitted questions. Questions can be submitted throughout the program utilizing the feature at the bottom of your screen that says Q&A. And please do not submit any questions containing personal health information. All right, so I will introduce our presenters. So we have Dr. Reinhardt. He's an orthopedic surgeon at Pennsylvania Regional Orthopedics. We have Dr. Schwartz. He's an orthopedic surgeon with Pennsylvania Orthopedic Associates. And we have Dominic Vendetta. He's the administrator at MUVE Health. So today's agenda includes myths and facts, options for alleviating joint pain, knee replacement, hip replacement, MUVE Health, and then we'll end with a Q&A session. All right, so first we'll start with Dr. Reinhardt and myths and facts. Take it away.
Good evening, everyone. Today we're going to talk about myths and facts about total joint replacement. First myth: I will not be able to move for weeks or months after joint replacement surgery. The fact is, we want you to start moving right away. So as soon as you get your hip or knee replaced, we want you walking that day. It's called walk therapy. Then we want you to continue the walk therapy at home. This helps build endurance, cardiovascular exercise, motion, strength to the joint that you had replaced, whether it's hip, knee. Another myth I hear all the time. I've been practicing now for 22 years. I've heard this for years. I'm too old to have my joint replaced, or I'm too young. I hear this magic number of 65. They have to wait until you're 65 to get your knee or hip replaced. That's a myth. Here's the facts. The facts are everything is based upon your age, your quality of life, your medical conditions. I've replaced knees in 37-year-olds. I've replaced knees in 95-year-olds, hips in 100-year-olds. So it doesn't really depend on your age. It depends on what your quality of life is. Physiologically, you may look like you're 90, but you're 90 by age, but you're really 70. So everything has different evaluations. So its appropriate treatment will depend on you with the doctor and what you're looking for out of your joint replacement. We'll talk to you about the risks of the surgery, the benefits of the procedure, obviously, which we'll talk further in this talk today. Another myth: I can no longer participate in any sporting activities after you have your joint replacement. Again, that's not the purpose of why we do joint replacement surgery. We want you to lead an active lifestyle. So you're allowed to do low impact activities such as golfing, swimming, doubles tennis, pickleball, cycling, elliptical, walking. I even have some of my patients run on their hips and their knees. We don't obviously want that to happen, but they do that for an active lifestyle. Now we have Dr. Todd Schwartz, who is an orthopedic surgeon at Holy Redeemer Hospital, talk to you about other options to help alleviate your joint pain. Take it away, Todd.
Thank you, Dr. Reinhardt. I'm Dr. Todd Schwartz. Welcome, everyone. Glad you could all join us this evening for some educationals about hip and knee replacement. But before we engage in any hip or knee replacement, there's options before surgery, obviously. So we begin with there we go. So the initial non-operative treatments are to manage your pain and your symptoms. That's normally done with over-the-counter medicines, Advil, Motrins, Aleve, Tylenols. They're all very helpful. Reducing the stress on the joints by reducing your weight is also very helpful. Keeping active and exercising and physical therapy can also help your joints move more freely, reduce the pain, reduce the stiffness. After the general conservative care is no longer effective, we engage in injections. So there's cortisone injections, viscoelastic or gel injections, and then now there's more biologic or stem cells like platelet-rich plasma or amnio injections, which are just starting to break into the field of orthopedics. And then there's other alternative treatments that include bracing, modifying your activities, and other types of pain meds as well. After you've tried all that, when do you know surgery is appropriate for you? So after you've exhausted all the conservative treatments we just discussed, the biggest factor is what's your quality of life? Are you able to enjoy life and do the things in life that makes you happy, that you want to do, that gives you quality? And if you have a feeling of impairment or disability because you can't walk, you can't get around, you can't live a normal life, you can't enjoy the sports and activities you like, then you're generally ready for the next phase of joint replacements. So rather than suffer from the constant injections, we can discuss surgery, undergo the surgery, and basically have a 20 to 30 year maintenance-free enjoyment of life with the knee replacement procedure. Joint replacements in general are very successful procedures compared to really all the other procedures in modern medicine. It has a very high success rate in reducing pain, improving your function. These joints last 20 to 30 years and beyond for most people. The complication rate is really very low. And we get you back on your feet actually pretty quickly for such an involved procedure. And we're getting actually better at that with our pain management and rapid recovery programs. We do like to tell people that the general recovery is 8 to 12 weeks-ish. Total recovery is up to a year. So you have to kind of keep that in mind if and when you ever choose to have this done. So in ways to prepare for the procedure, we want to optimize the patient medically. That means optimize your high blood pressure, your cholesterol, specifically your diabetes, any other medical problems you may have like sleep apnea, renal disease. These all have to be optimized and be as healthy as possible in order to reduce the risks and recover as quickly and as safely as possible. Weight is another factor. An elevated BMI is a risk for enhanced complications after joint replacements. So we'll often ask you to reduce your weight. If you cease tobacco use and alcohol use up to 6 weeks before surgery, you can actually improve your outcomes and reduce your risks. If you have any nutritional deficits, like low proteins or not getting the vitamins and minerals that you need, these supplements can actually help your healing and recovery. And physically, if you're more physically fit, then you will recover quicker, be able to ambulate sooner, and have enhanced range of motion. So all these guidelines will be directed to you by your physician, Dr. Reinhardt, and myself, and whomever. And following these will help ensure a successful outcome. There's many different kinds of joint replacements. And at Holy Redeemer, we are on the cutting edge of performing, whether it's a total replacement, a partial replacement, certain realignment procedures are all alternatives to total joint replacements. But if you do need the joint replacement procedure and hip and knee arthroplasty, then Holy Redeemer is the place where we specialize in this and are procedures are on the cusp and the innovative edge of ensuring the best outcome and the longest survivorship. So if we move on to what we need to go up to the procedure, now we can discuss the actual knee replacement itself. I will be focusing on the knee replacement. Dr. Reinhardt will then discuss about hip replacement. So knee replacement in itself is when you have severe arthritis of the right knee. That means the surface of the joint has worn out and you essentially have no cushion to protect the bone, and you have like a bone rubbing on bone, which is very, very painful. That's the general wear and tear of osteoarthritis, which is by far the most common type of arthritis, about 90% or so. You can get osteoarthritis after an injury. That would be post-traumatic arthritis. There is rheumatoid or inflammation arthritis, where the soft tissues get inflamed and that wears down the joint. You can get crystals in the joint. That's gout and pseudo-gout. They can also cause arthritis and debilitating joint pain as well. Obesity, elevated BMI, extra stress, overuse, these can all can be reasons to wear the knee out even quicker. So here we have x-rays about a normal knee. On the left, you have good preserved joint space, you have a good alignment. This is the x-ray of a fairly healthy knee. On the right, we have no joint space here medially. If you look at it, there's a little bit of a bow. That's called a varus alignment or bow-leggedness. And the bones have kind of shifted slightly where there's a bit of an overhang. So this would be an x-ray of a fairly involved arthritic knee. And then here we have more of a post-traumatic arthritic knee, where this person had an ACL, the knee wore out, and it had the same findings. It had no joint space here on the inner aspect of the knee. The bones have actually shifted side to side, and this would be an example of severe arthritis on x-rays. And when you look at the alignment, people become more and more bow-legged with the arthritis. The legs bow out more from the hip, knee, ankle alignment. So the procedure for the knee is to remove most of the inner components of the knee, which is the surface cartilage, the anterior cruciate and posterior cruciate ligaments, and you replace that with metal and plastic. And so here we trim the edges of the femur. We put the femoral component on. It can be press fit or cemented. And then we do that with the tibial component. And then we have the plastic in between, and that acts as the bearing surface for the new replaced joint. We also do the undersurface of the kneecap in most cases. And that represents a knee replacement. And here's an x-ray. So here's a frontal view, the femoral component, the tibial component, the space is the plastic, and here's the side view of what a knee replacement looks like on x-ray. So after the procedure, as mentioned, the recovery takes about 8 to 10 weeks to get most of the improvement. Again, total healing is up to a year. We do get you up and on your feet as quickly as possible, including the day of surgery. And that's done by immediate and aggressive physical therapy and occupational therapy. They work on range of motion, strengthening, get you walking up and down the hallways and back on your feet as quickly as possible. After which you can really enjoy most of the general sports and activities that you did before. Mostly low impact exercises will extend the survivorship, but these knee replacements generally last 20 to 30 years and beyond. So that's a good example of a knee replacement. I will turn hip replacement over to my esteemed colleague, Dr. Reinhardt.
Welcome again. I'm Dr. Reinhardt. I'm going to talk about hip arthroplasty or hip replacement surgery. The benefits of hip replacement are, number one, to obviously reduce pain, increase your range of motion and function, and obviously improve your quality of life. Here's an example radiographically of a metal hip replacement. Obviously, hip replacement surgery comes in parts. There's a stem for the femur. There is a head. There is we call a liner, and then there's the acetabular shell. So there's 4 really parts to the hip replacement. It's modular. The benefits of modularity are everybody's not created equal. So we can adjust patients' leg lengths. We can adjust the stability of the cup in different angles to give people more stability. People are shorter, people are longer, people are wider. So all these things help us with the total hip replacement. Total hip replacements, a lot of people ask me all the time, what's it made out of? The old components were stainless steel and a high molecular weight plastic. Now it's more titanium, which is more biocompatible with the human bone. Here's an example of a model of a hip. I'm going to push the play button here. You're going to see this is what the hip does. It moves just like your native hip would. When we put the artificial hip in, you've got your metal liner, you've got your stem, you've got your head and neck, and then you've got your liner here. And it allows for the normal motion and freedoms just like your native hip did before it became arthritic or traumatic and lost its motion. When there's hip replacement, a lot of people will come to me, patients will say there's different approaches to the hip. You can go through the front, you can go through the side, you can go through the back. The most conventional surgical approach, which most surgeons do in the country, is the posterior hip approach, where you go through the back of the gluteus muscle to enter the hip joint. I'm one of the surgeons at Holy Redeemer Hospital that do more minimally invasive surgery. I do it through the front. And that's a different approach to the hip, which we'll talk about. Again, the going through the back or posterior, you have to go through the gluteus muscle to enter the back of the hip joint, to remove it, to replace it. You're cutting some muscles and tendons. Same thing if you go through the side of the hip. You go lateral through the hip muscles to enter the front of the hip. For minimally invasive surgery, or anterior, which is a true minimally invasive technique, you're allowing approach to the hip without really disrupting any of the muscles. You're not cutting any muscles. You're actually going through what's called an interval, where you're splitting the muscle and getting to the hip joint to replace it. What this does, it preserves stability of the hip. It reduces the risks of dislocation, which can happen with the hip replacement prosthesis. Your limitations post-surgery, after you have surgery by different conventional approaches, the doctors will place you in a special pillow. They'll tell you can't bend your hip a certain direction for a certain amount of period of time. When you do the anterior approach, we don't have to do those restrictions after that surgery. Also, in the past, I used to do the more conventional approaches in the past, and the reason I switched is because of a lot of patients that over time would have a limp. This limp wouldn't be forever, but it would be temporary. But my patients would complain about it. So by anterior approach, there is less chance of having any limp or no limp at all. Again, with the modernized anterior hip approach, which people may have heard about, again, it decreases your pain since there's less muscle cutting. There's a shorter rehabilitation since the muscles are working faster. There's a shorter hospital stay. Most people now are staying in the hospital only 24 hours. And there are places around the country, and we're close in Pennsylvania, to do the same thing, where we're going to start doing patients as an outpatient. The skin incision is much smaller going through the front, but again, this is also depending on the patient size. Obviously, if you're 5 foot versus a person who's 6'4", you're going to have a bigger or smaller scar. Again, there's faster return to activities of daily living because of the anterior hip approach. There's less blood loss, and as we talked about before, the hip is inherently more stable. Since you're not cutting muscles, you're not weakening them, there's less chance for them to dislocate or the ball and the socket to separate. And as I stated before, the reduced risk of limping is significant in the anterior hip approach. So long-term care of your hip, like Dr. Schwartz says, they last for a long time, 20 to 30 years. If you're good to your hip, the hip will be good to you. You have to follow your doctor's instructions to minimize complications, improve the quality of the hip replacement and your quality of your life. You know, there's simple rules that we tell patients to follow. I have my patients follow with me every 2 years to get an x-ray. What this does, I radiographically look at the hip to make sure, or the knee, that the replacement is still in good alignment position, it's not loosening. And if it is, you can then make changes sooner than later without disrupting the whole knee replacement. So if you do have to replace the knee again, if you catch it earlier, it may not be as bad as if you wait 10 years. You also have to tell your hip or knee surgeon if you have experienced any joint pain, even if you're having joint pain at 10 years per se, there may be a reason why. It could be tendinitis, it could be another problem, and that's a good reason to follow with your physician. Also, when you get your hip, your knee replaced, the Orthopedic Academy recommends that you take antibiotics before you get any dental cleaning or any surgeries to prevent the possibilities of an infection into the joint replacement. These are things that you can do to help lead to an active lifestyle and keep your hip and knee lasting as long as it possibly can. Now I'll pass on to Dominic Vendetto to talk about new and exciting outpatient surgery with the MUVE Health.
Hi there, I'm Dominic Vendetto. I'm the administrator of the MUVE Warminster Surgical Center, which is a joint venture surgical center which is owned by both MUVE Health and the Redeemer Health System. We are located in Warminster, Pennsylvania, and it's a surgical center that is in network with most insurance providers, and we accept we have contracts with Blue Cross Blue Shield, Aetna, and Cigna, and we also accept Medicare, IBC, Medicare Advantage plans, and also Aetna Advantage plans. The one thing about MUVE that is unique in today's world is that we utilize a bundled contract system, which is very beneficial to the patients because it is basically it offers the patient one bill for their surgery. The patient pays the surgical center, and that covers your surgery, which pays for the physician, the surgical center, your anesthesia, your implants, and there's no bills that come in the mail from all those other departments that you may see 2, 3, 4 months later, which you would normally see from having your surgery in a hospital. So what makes MUVE different? Our model is an integrated set of purpose-built facilities, technology, people, procedures, protocols, and processes. MUVE is a program, not just a procedure or a site of service. MUVE is not just a surgery center. MUVE is a program designed for outcomes. The facts and the problems to solve about joint replacement. Currently, 1 million total hip and knee replacements are performed annually in the U.S. That number is going to increase to more than 3 million by the year 2030 with the baby boomers coming to age. And right now, Medicare is paying $7 billion per year for joint replacement. Currently, there's more than 5,000 ambulatory surgical centers across the country, and less than 5% of them are performing joint replacements. A majority of the total joint replacements being performed in the surgery center are of low acuity. And what that means by low acuity, the physicians are handpicking the patients, and they're picking patients who are at low risk, and they have low comorbidities. And 70% of the total joint replacements that are being performed in a hospital setting are suitable to be done in a MUVE model like we are now. So you have a tradition, here's our MUVE model compared to a traditional surgery center delivery of care. With a surgery center, you have fragmented care, with us at the MUVE model, you have an integrated care with 365 days of navigation. As a patient here, you would have a nurse navigator assigned to you from the day that your surgery is booked. Going to a surgery center, you would have varied cost. With us, you have a predictable cost because we have a contracted rate based off of our contracts with the insurance companies. While a surgery center gains success through volume, our success is based off of value. And we're based off of outcomes, and that's and word of mouth from patients. Surgery centers gain their money for fee for service, but we have bundle payments, and we have warranty because with the payers. So we offer we believe in our outcomes, and we guarantee the payers that our results are so good that we offer a 90-day warranty to the payer that if you have any issues, we are going to guarantee your care for 90 days. And if there's any issues, we're on the hook for that care. We work with employers where we can have, for a larger health system or we can negotiate like a large base rate for total joint replacements, and it helps cut costs for a health system. For a surgery center, they may not just be doing orthopedics or total joint replacement, but at MUVE, this is all we do. 5 days a week, 52 weeks a year. Patients at a surgery center, they have limited patient engagement, but for us, since we're based on outcomes, that's all we do. We focus on the patient all the time. We start focusing on the patient from the time that the patient is booked. We hear the patient's stories from the navigators. We hear about what their likes, their dislikes are, what their food preferences are, what kind of music they like to listen to. And these are the things that we focus on so that when you're here at the MUVE Center, you're comfortable, and you have all those little touches here that you already know that the team here knows who you know. We know who you are, and you feel comfortable, and it becomes a more pleasant experience than being in a hospital. We are data-driven, and we have cutting-edge technology here at the center. And when you're at a surgery center, when they discharge you, you're given discharge instructions, and you're set off to go home. Here at MUVE, after you're discharged from the surgery center, you go down the hall and you spend a couple of days in our MUVE surgical suites. And I have some pictures to show you later on in the slides. That is basically like being in a five-star hotel that has 24-hour nursing care, where basically is a concierge service. We also have physical therapists here on staff that help move you through your care, and the nurses provide education to get you ready to go home and prepare you to be taking care of yourself after your joint replacement. The nurse navigators, they put you on a journey towards your getting yourself ready to go home. So here's your journey through your nurse navigation. So you go through your pre-consultation, you meet your navigator, you talk about your personal goals, and then your navigator gets you to go online through our online platform called Force Therapeutics, and you go through online training and you watch videos and take tests. And on your day of surgery, you come to the center, you have your surgery, obviously, and then we get you walking. After your surgery, before you're discharged from the recovery room, you need to walk 100 feet to get discharged. And then you spend your time in the stay suites. And then you're basically, after you're discharged from the suites, we continue to stay engaged with you for upwards of a year. You have 24/7 access to nurse navigators. You're able to call them, text them, email them through all of our platforms. And we even send you send you a little card on your 1-year anniversary that you've gone through your program and achieved your goals. Here's some clinical outcomes matching our numbers versus some of the industry benchmarks. Industry norms for ambulating the day of surgery. 9% of total hip replacements and 5% of total knee replacements ambulate the day of surgery. 97% of our patients ambulate in recovery room the day of surgery. The average length of distance walked to the day of surgery, 150 feet is the industry norm before discharge. You're going to walk more than a half a mile before you're discharged from the MUVE suites. Surgical site infection rate, 1.7% is the industry norm. We're less than 0.5%. DVT, 1.6 is the norm. We're at 0%. Hospital readmission rate for 7% for hips, 9% for knees, and you can see our rate of 0.7 and 1.4. Some pictures here of the MUVE Center. This is our pre-op and post-op area. Brand new state-of-the-art center. It's about a year old. This is one of our operating rooms. This is our stay suites. Nice picture here of the center of Philadelphia from the Ben Franklin Bridge. This is our common area. Come here, you can sit and have your breakfast, lunch, and dinner. We have catered meals for our patients. And this is one of our rooms. This is the Murphy bed. It goes up during the day. We encourage you to bring one of your spouse or one of your loved ones to stay with you. We have smart TVs here so you can watch your TV as you're recovering. There you go.
All right, thank you to all of our presenters. That was very informative. So we will move on to the Q&A portion of the presentation. Don't forget to please submit your questions with the link below. It says Q&A on it. So let's start with our first question. I am 75, overweight. Am I a candidate for knee replacement? Dr. Schwartz, can you answer this?
I can, yes. So this is a common question we have. Is there an age limit, a weight limit? Essentially, no. It's based mostly on a patient's physiologic age, not their actual chronologic age. And as Dr. Reinhardt had mentioned, we have people in their late 30s that undergo joint replacements to the 80s and 90s. And data shows that there's still excellent results even in the elderly with a slightly higher risk for certain issues. Weight, yeah, there is a ceiling for weight, and that does depend on the BMI, and it depends on where you are and how overweight that number is. But there are strategies to try and reduce the weight in order to optimize you medically and reduce the risk to undergo the procedure safely. So I think that answers that question appropriately.
Thank you. I have another question for you. After surgery, is it common to have numbness of the knee month later or more?
Yeah, I do hear that often around the knee and the hip. So what happens as we make the incision around the knee or even the hip, there's superficial nerves that live on the surface of the skin, and they pass generally longitudinally. So when you incise the skin in a certain length, you're bound to disrupt the natural pattern of these superficial nerves. So one of the residual effects is to have numbness on one edge more so than the other of the knee or the hip. Most of that improves with time as the other nerves grow back into the area, but you may still have some residual numbness. The numbness does not affect outcome. It doesn't affect function. It doesn't cause pain. So really, it isn't much of an issue other than it just feels kind of weird afterwards.
Thank you, Dr. Schwartz. All right, next question. Are surgeries being delayed right now due to COVID-19? Dominic, can you answer that?
Yeah, I can answer that. Right now, no, they are not being delayed due to COVID. They were being delayed back in March and April by the state, but right now it's a very fluid situation depending on how the pandemic goes. With the upcoming flu season, that could always change, but right now, elective surgeries are ongoing.
Thank you, Dominic. And I actually just had a question pop up. How long has MUVE been providing surgical services?
We opened in November of 2019.
Thank you.
You're welcome.
All right, next question. Are there travel restrictions after surgery, and how long until I can fly safely? Dr. Reinhardt, can you answer that?
Oh, absolutely. So the Orthopedic Academy recommends that you wait 48 hours to fly anywhere after your hip or knee replacement. Personally, I try to tell my patients, if you don't have to, don't do it. There's this theoretical risk that you're at increased risk for that condition called a blood clot, called a pulmonary embolism, or a DVT. So I tell my patients, look, try not to plan any vacations, try not to drive too long, but if you do, try to limit your driving to 2 hours, get out of the car, move around, because we do get a lot of patients to our center from the Poconos, from New Jersey, and they have to travel for their surgery. So it's usually, that's how I limit it. No flying for 48 hours and then driving limited to 2 hours at a time.
Thank you. I have another question for you. Do I need a full-time caregiver at home during recovery?
After surgery, you don't need a full-time caregiver during recovery. We have home nursing come out to see you. We'll have home physical therapy come out to see you. We'll have occupational therapists come out to see you. But you shouldn't be alone, but you should have at least some people come and check on you, but you don't need a full-time person around the clock.
Thank you. Next question. I have heard it is really painful and recovery is difficult. Is this true? Dr. Schwartz, would you like to answer that?
Yes, I can certainly address that. So hip and knee replacements are painful. We're opening up the joints, we're cutting the edges of the bone, we're inserting and impacting components on the bone. However, with the new rapid recovery program and the innovation to get people on their feet, we've significantly reduced the amount of pain that people have afterwards. And that's with a technique of preemptive medications where we give the pain medicines before, during, and after. And we've discovered that it's much better and effective to prevent the pain than to try and reverse the pain. So yes, the answer is yes, they are painful, but they're much less painful, and we've had patients really go through this whole process with little to no pain at times. Although I can't promise or guarantee that, but it is possible, and we are much better at reducing pain post-operatively.
Thank you, Dr. Schwartz. And last question, when can I return to work after a joint replacement? Dr. Reinhardt, can you answer that?
Yes, absolutely. So a lot of patients obviously are retired, so there's no issue for return to work, but the younger patients that are working, depends on your job. Obviously, if you're a construction worker, you're not gonna be able to go back to that job right away. So it depends on what you do, how old you are, and what your job entails. So if you have a desk job, most people in my practice go back to work around 3 to 4 weeks at a desk job. If you have a heavy duty construction type job, it's usually 3 months before they go back to that, to 4 months to their regular job, to that lifestyle.
Thank you. All right, that is all the time we have for questions and answers. Thank you all for joining the webinar tonight. And a special thank you to all of our presenters. For more information about our orthopedics program, please visit holyredeemer.com/orthopedics. Have a great night and stay safe.
Thank you, everyone.
Thank you.